I mean, no one would bat an eye saying that, oh, I'm going to get my gestational diabetes screening or I'm going into labor early, but I'm depressed, I think is just not something I hear a lot.
Mm-hmm. Yeah, so why does this matter? It can lead to poor outcomes like preterm birth, low birth weight.
I'm sorry, I don't mean to laugh. Just the way you said that, it was like, so why does this matter? Of course it matters.
Right. Yeah, we have to say that. We have to remind ourselves why it matters.
Right.
As
Yeah.
long
That
as it's
that
it's
I mean,
depressed.
absolutely. No. Again, I don't mean to laugh. I think you're absolutely correct that sometimes we take it for granted that people should feel good and that anyone who's depressed, it matters. But you're right. It has other effects over and above that to the kid, to the healthcare system, to everybody. So yes, why it matters.
No, that was pretty funny. I think I'll keep that. That's pretty good. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Welcome back to the podcast. So today we're talking about perinatal mental health. It affects 1 in 5 women during pregnancy or the first postpartum year. And depression and anxiety are most common. And we're going to talk about prevalence, what are different conditions you can have. And then we'll talk about the causes, although a lot of it is multifactorial. And then we'll talk about treatment and management. We will also address, very importantly, paternal perinatal mental health. Very neglected, but so vital to the overall health of the baby and the health of the entire family. And then, if we have time, special populations as well. So, those who have dealt with infertility issues, miscarriage, NICU stays. So, yeah, we'll go through what we can and yeah, we'll get started.
And I think that's a really good point that there are special populations or special circumstances that people think of in the context of perinatal mental health, but just how common this is in general. And I think it's not really that talked about. Even in psychiatry, we all sort of know that depression can be a biological illness, that nothing has to happen, that people can develop depression. In fact, that's part of what defines it. But in the perinatal space, it's almost like something has to happen in order for someone to be justified in their depression. Otherwise, it's just sort of, oh, well, this is just a normal course of what's happening. Like it's not recognized in the same way.
Yeah, and as I was reading through this, that was one of the big issues was that postpartum depression was often labeled as baby blues. And people don't investigate it enough. They brush it off. You're going to get over it in a month, and it doesn't happen. And so there's definitely an under-examined nature to this.
Yeah, I thought that was fascinating, just reading through the epidemiology of it. And again, this is our field. We should know more about this, but I had no idea that depression is more common in the perinatal space than gestational diabetes or than
Mm-hmm.
preeclampsia. And everyone goes through screening for those two things, but I think screening for depression is kind of a relatively new thing.
Yeah, I do think it's newer. And I think also it depends on what area of the country, what kind of institution you go to. Certainly, if you go to an academic center, they'll be on top of that. But if you go to more remote areas, it might not be addressed as openly. So, in terms of prevalence, depression during pregnancy is about 14% of women, and then depression postpartum is about 10%. Anxiety is a little more common with an estimated global prevalence of about 12.3% in the postpartum period, and oftentimes they're comorbid with depression. And so, like Dr. Kelly was saying, this is more common than gestational diabetes, which is 2 to 10% of pregnant women. Preeclampsia, which is when you have really high blood pressure, that's 2 to 8% of pregnant women. Depression and anxiety can be as common as preterm labor, which is 14 to 16%, and yet it's not commonly discussed or screened for.
Right. I mean, no one would bat an eye saying that, oh, I'm going to get my gestational diabetes screening or I'm going into labor early, but I'm depressed, I think is just not something I hear a lot.
Mm-hmm. Yeah, so why does this matter? It can lead to poor outcomes like preterm birth, low birth weight.
I'm sorry, I don't mean to laugh. Just the way you said that, it was like, so why does this matter? Of course it matters.
Right. Yeah, we have to say that. We have to like remind ourselves why it matters.
Right. Yeah.
Wellness
That,
is
I mean,
depressed.
absolutely. No, again, I don't mean to laugh. I think you're absolutely correct that sometimes we take it for granted that people should feel good and that anyone who's depressed, it matters. But you're right. It has other effects over and above that to the kid, to the healthcare system, to everybody. So yes, why it matters.
No, that was pretty funny. I think I'll keep that. That's pretty good. Yeah. Of course, you can imagine impaired attachment. There's a lot there. We can do a whole nother podcast on that. And then also there's a risk of developmental delays. Very awful things can happen to the mom if the depression is really unmanaged. Suicidal ideation, substance abuse, overdose. These can be leading causes of maternal mortality. And of course, the economic burden on the society, it's a pretty significant cost to healthcare. So we can talk about different types of conditions and maybe we'll start with during pregnancy. And I think also just a disclaimer that we're going to touch the surface of these conditions. And there's so much more that you can go into under each category. But our goal is to give you an overview of what perinatal mental health means.
Yeah, and I think that's a good reminder. And we'll get to this later, but this is becoming its own field within psychiatry, its own specialization. So it's a huge topic.
Yeah, exactly. So, first and foremost, we want to talk about anxiety during pregnancy because it is very natural to start to worry about your baby's health, your own health, whether you can be a good parent or not. And then I think also importantly, you might worry about your relationship with your partner if you have one, relationship with your family members, how that changes, grandparents and uncles and aunts. There's a lot of changes that are happening. Also, there's very significant biological changes. This does have to do with the changes in your hormone levels. Your heart is working 30% harder. Your blood volume is massively increased. So it's very understandable that you have increase in worry and stress. However, there's a difference between normal worries and more serious anxiety disorders. Sometimes they call this antenatal anxiety. So this is when the anxiety becomes all-consuming. You can't control it, you can't regulate it, and it interferes with your day-to-day function. That's the key here, is that if you're not able to feed yourself properly, take care of your hygiene properly, you can't work if you are working, then you should really speak to your family doctor or a psychiatrist because there are ways to manage this through help.
And I think a lot of people, when we bring that up, jump to medication and, well, I don't want to take a medication that might harm the baby. And that's why this is a whole field, is that one, there's much more than medication, and two, there are, even in the medication world, things that are studied more or less for safe use in pregnancy. But just going to see a psychiatrist or a mental health professional does not mean you will necessarily leave there with a prescription. That's a very understandable concern, and that shouldn't get in the way of opening a discussion with someone.
Mm-hmm. Yeah, it could be, lifestyle changes are huge. Things like nausea and fatigue are a big part of pregnancy. So if you can adjust your schedule to fit the changing needs of your body, that could help a lot. And then, of course, for mild to moderate depression or anxiety, psychotherapy is first line. If we're looking at moderate to severe, we may start to bring in medications, but that's certainly not the only answer. And then zooming forward, we do want to differentiate between, again, baby blues and postpartum depression. So up to 85% of pregnant women or postpartum women experience baby blues. That's a huge number. It has a lot to do with your progesterone and estrogen dropping 90% within the first day of labor and delivery. So there's significant physiological changes that are happening. And the key difference here is the intensity and the timeline. So for baby blues, it typically resolves without treatment in 2 to 3 weeks after childbirth. But in postpartum depression, it does not. It takes away your motivation, your concentration. It changes your appetite and sleep and energy level. And then you have ruminating guilt, helplessness, hopelessness, worthlessness. Sometimes moms can become very irritable and angry. You lose interest in your baby. And then you might even have intrusive, scary thoughts like wanting to hurt yourself or the baby. So we'll talk about that too.
Those are really important differentiators because, like you said, it's common, 85%. That's more people develop baby blues than develop nausea during pregnancy, right? And that's just expected as part of the course. So it's like the difference between someone who's not pregnant saying, I'm sad and I'm depressed, right? Like there are differences. So, but it can over normalize the experience of having some sadness when really that can be very different than postpartum depression that has a lot of the characteristics that you were discussing, either the severity or it just goes on forever without seeming to remit.
Yeah. It's also hard when you're surrounded by family or people who care about you. Having given birth in this new life, it is so full of joy and so happy. People around you sort of expect you to be jumping up and down in joy when you've gone through 9 months of transformation in your body, just creating an entire organ, by the way. Placenta is created and delivered with the baby. Sometimes family members will maybe say things like, it's okay, you're going to be really happy in a couple of weeks, and brush it aside. But you really have to listen to you, what feels right to you, because everybody else will want you to be a happy, present mom, but only you know whether you can get there.
And even if it does turn out that it's quote unquote just baby blues, you can still get therapy. You can still see a therapist. You can still get support. That doesn't mean you have to just muscle through it. There's still room for either mental health or support groups or all of the tools that we have at our disposal.
Absolutely. So then postpartum depression we hear pretty often now, finally, but postpartum anxiety and postpartum OCD, maybe not so much just yet. About 6 to 8% of pregnant women or postpartum women experience severe anxiety. And this can oftentimes feel like more somatic symptoms, like physical symptoms. So you have shortness of breath, you have tingling sensation all over, you feel dizzy, chest pain, stomach pain. And a lot of it has to do with intrusive thoughts of wanting to harm yourself or the baby. A lot of people describe if they're standing on a higher ground, they have this intrusive thought of dropping the baby. And it's terrifying and it's awful and scary, and you would never do that, but it's the distress of that thought stays and you can't get it out. When that becomes even more severe to the point that you're having compulsions, so you are checking relentlessly over and over the baby camera, or you are washing the baby bottles 17 times, and if you don't do that, you can't use it. These kind of compulsions, that's when you're looking at postpartum OCD, and this happens in about 4% of pregnant or postpartum women. And again, when you are a new parent, you have to be pretty meticulous. And so part of that could be what we call egosyntonic, meaning you like it, you're glad you're organized and you're a planner and you follow through and it feels good. But sometimes, especially with these intrusive thoughts, oh, I can introduce a virus to my baby, I gotta wash the bottle over and over again. But I know it's not doing anything different. And by the 17th wash, you're just disoriented. So if you're feeling more that way, that's what we call ego dystonic, meaning you do not like it. It's very disturbing and distressing. And that's when we have full-blown OCD.
Yeah, I think that's such an important clarification. And I think people are so either embarrassed or ashamed or hesitant to talk about these sort of thoughts or these sort of impulses because they worry that it paints them as a bad person. Or some people think that if they talk about it, it's going to get stronger. They're sort of releasing it into the world. And really talking about it is what makes it smaller. But
Hmm.
it is one of those things that I feel like just over time you get to see as a practitioner there are definitely times where I'll be talking to a patient or a new dad or a new mom, and just something about when I'm asking about symptoms, the way they pause, I almost know like, oh, they're having intrusive thoughts and they don't want to tell me about it because they're worried about what I'm
Hmm.
going to think. Like you just know that
Yeah.
that's what's going on. But
Yeah.
there's so much that gets in the way of being able to talk about that. But the point is that it's a symptom, that this is not something you're going to do or something that you're even closer to do. In fact, the whole reason your brain keeps throwing it at you is to get you further and further away from it. But it's really upsetting to go through.
Yeah, that's such a good point. The shame of it, right? Especially with OCD, you can feel it when somebody is having that moment of shame.
Yeah, that's the psychoanalysts. They used to say,
Yeah.
right? The truth is in the pauses. That's where the real sort of cognitive processing is working. And I think that's something that happens over time. When somebody is self-editing like that,
Yeah.
there can be a lot of shame or guilt or something in there that is worth trying to get to.
Yeah. Beautifully said. Yeah. So we're going to increase in intensity in terms of conditions. So then you could also have post-traumatic stress disorder related to pregnancy. And this one makes me really sad because, you're looking at the grueling efforts and disappointments that come with infertility issues. You just never can predict conception. And thankfully, there are things like IVF, but, that's not always accessible in the state of the country right now. So that part is really devastating. And then also miscarriages. I cannot imagine, especially when you hear about like third trimester miscarriage.
Yeah.
Whew. So there is pretty significant risk of trauma involved in this, not to mention emergency C-sections, NICU stays,
Yeah,
complete
stillbirths, all of it.
stillbirth, right? Complete unpredictability. Mother Nature knows no limits. You're just at the mercy of it. So, 9% of pregnant or postpartum women do experience PTSD. This can look like changes in your cognition, so your ability to like focus and concentrate, get tasks done, changes in your mood. You might be really on edge and start to avoid certain things that are associated with that traumatic event. Also, prior trauma history, ACEs, adverse childhood events, do increase the risk of postpartum and perinatal PTSD 4 to 7 fold. So, if you do have a history of trauma, make sure that you have a safety net around you.
And that brings up something that's really important that I don't think we talk about enough. It's that this can be protective as well. You don't have to wait for something to get to an extreme state before you seek help. Just like we talk about prenatal care. Literally, it's in the name. We don't talk about prenatal mental health. Right?
Hmm.
Unless something has come up. But if somebody has a history in their family, or frankly, somebody just wants a little bit more support going through the process. The idea of seeking out help and establishing that relationship early so that it's there when you're really going through all of these changes, positive or negative. All change is stressful, even positive change. And there's no bigger change that I could imagine than having a child. So having somebody on your team ready to be there with you, not just physically with OBGYN or a doula or a
Hmm.
midwife, but in the mental health space as well, I think is a great idea.
Yeah, it's all about preparation and just even having establishment with someone, right? That is so comforting. Okay, we've got two more we want to talk about. Moving further into bipolar disorder. So, 3% of pregnant or postpartum women experience bipolar disorder. So, we're talking about manic or hypomanic symptoms, episodes that alternate with depressive episodes. These include significant shifts in mood that last for days to weeks and changes in energy, activity levels. You are not really able to carry out your day to day tasks. So, Bipolar disorder is really important to consider because oftentimes women with bipolar disorder have a slightly different age of onset for mania. And so they could be a little bit older, maybe in their 30s. And so you may have gone all your life with just depressive episodes. And then you become pregnant, and all of the distress and stress that comes with it sets off a manic episode that can very well happen. And so, if you're experiencing pretty severe mood swings like that, that lasts days to weeks, you can't sleep, you're talking faster than usual, your thoughts are racing really fast, definitely talk to a psychiatrist. We do have mood stabilizing agents, and they do carry different risks, but they're available.
Yeah, I think that's true. And, as we're talking about more substantially impairing conditions, sometimes they require more substantial treatment. And some of the mood stabilizing medications can be a bit of a riskier proposition during pregnancy. And so that is when I would strongly recommend talking to somebody who's a specialist in the field.
Yeah, right. And relatedly, with peripartum or postpartum bipolar disorder, psychosis is also something that women can experience during or after pregnancy. And this is a medical emergency. So this is very rare. This is 1 to 2 women per 1,000 births. But very importantly, this is when you are losing touch with reality. Sometimes you're not exactly sure where you are. You might hallucinate. You might hear voices other people can't hear or see things other people can't see. You have pretty severe paranoia and delusions. For example, you might think your husband is trying to hurt the baby, or, your partner is trying to hurt the baby. And so this is when we have to essentially get you to the emergency room, get you into a hospital, stabilize you into a safe place.
And I think that it's not the person's job to distinguish this. It's the mental health professionals, but it is a point of distinction from OCD, where somebody may have negative, egotystonic, intrusive thoughts of harming the baby versus the psychotic, distressing, but egocentric, they believe it wholeheartedly, thought that maybe while they're pregnant, the baby is hurting them, robbing them of nutrients or something. Like there is a distinction between the two. I do think that a lot of people are maybe more hesitant to talk about OCD and intrusive thoughts because they worry that they're psychotic or going through psychosis. But that's what we're here to help tease apart. You don't have to go through that alone and figure that out yourself.
Right. Oh, yeah, that's such a great point, Dr. Kelly, because when I've seen women with psychosis, and especially in the postpartum stage, they're convinced. They are very convinced that this is the way to handle this. Nobody can change their minds. And they start to isolate a lot. They're not seeking help necessarily. So their family members are bringing them in. Also, a very important point is that if there is postpartum psychosis, especially for the first time there's a psychotic episode, it's very likely that there is an underlying bipolar condition. And so when you see postpartum psychosis, as psychiatrists, we're immediately thinking, okay, there's likely an underlying bipolar or schizophrenia, schizoaffective disorder going on. So we might be a little more aggressive with our medication treatment and stabilization. So, in terms of causes of mental health conditions in the mom who's carrying the baby, there are obviously biological changes. There's dramatic changes in hormones during pregnancy and then immediately postpartum that can impact the mood. So there is a dramatic drop in allopregnanolone, which is a neuroactive steroid that modulates GABA A receptors. And this is a widely recognized mechanism underlying postpartum depression. So recently, there's been exciting new FDA-approved treatments for postpartum depression, and these include brexanolone, zuranolone. And so definitely this is something where you want to talk to a perinatal specialist, psychiatrist about. And then another big association that we found over the years is that postpartum thyroid function can mimic or exacerbate depressive symptoms. So regular thyroid screening is really important too.
Mm-hmm.
And then there are psychological causes. So this runs the whole gamut of what is going on in your environment. How is your support system like? what is your family of origin and what are their expectations for your pregnancy, changing roles and relationships, responsibilities, and just the idea of there's a certain level of losing freedom, right? Because if you're becoming parents and you're taking care of this life, you better be prepared to make compromises, sacrifices. Eventually, I think you want to find a balance, but especially, in the early days, it is an entirely different life. And so the psychological impact of loss and gain of something very new, very rewarding, but very hard. And then socially, we're talking more practical things like your finances, your jobs, where you're going to stay, who's going to stay with you. The number one reason for fights between couples is financial, right? So as you are having to buy more things, go to all these doctor's appointments and getting expensive car seats, and how does that impact your relationship if you do have a partner, or your sense of safety, because financial security is a major part of your sense of safety and stability. So, not to mention, we are kind of out of it now, but during the COVID pandemic, the social isolation and all of the uncertainties that came with, should I vaccinate? Should I go on this trip and expose myself to viruses? And nowadays, there's also like the measles outbreak. So
Right.
there's so many factors socially, societally, that can ramp up your anxiety so high. So it's multifactorial. The causes of maternal mental health issues they're so vast.
And I think I'm glad we're talking about it as maternal mental health, because I do think that there's the spectrum of sort of normal and when to be concerned. But I think that line in that gray zone sometimes gets fuzzy. And I think people dismiss as just part of the package things that are really stressful and really difficult. And I think there's nothing wrong with being stressed out. We talk about anxiety and how it can be protective, and it's really your brain trying to keep you safe. And so, of course, with a huge change like this, anxiety is going to come up. It would be almost unusual if it didn't. And the idea that there are people to help you with that there are ways to move through that you don't have to just sort of sit and take it, or at worst, blame yourself for feeling those feelings.
Absolutely. Oh, man. Yeah, I think the sense of guilt, it's pervasive. You always feel like you can do more. And it's not just limited to the mom. I think it happens to the partner, the family members, everyone around. And so moving right into treatment and management, actually, this is a really good segue, because first and foremost, before anything else, I would say go to therapy. First line for mild, moderate, even severe depression, anxiety, OCD symptoms, I would say first line psychotherapy, because the medications for depression, perinatal, or postpartum do come with potential risks. And, I'm almost hesitant to even consider that if someone is not in therapy. A lot of this is reflecting, pausing, processing, coming up with coping skills. And if you don't do any of that, you jump right into pharmacological or any other form of treatments, it kind of misses the whole point. Right. The whole point is that you have a life transition. It's a milestone, and it requires space to respect that transition within your mind. So first
Right.
and foremost, yeah. And there are evidence-based therapy modalities like CBT and IPT, which is interpersonal therapy. And, it's interesting because I was thinking about this. So it's really, really difficult to do randomized control trials or research because of the ethics behind this. So if someone is pregnant, and psychotherapy might be less risk of harm, but the medications, you certainly don't want to put a pregnant woman through medications with a lot of potential side effects. And also, possibly she could be on a placebo where nothing happens. And so,
Right.
I think the research is so limited, but of the evidence that we have, CBT is easy to research because you have a manualized protocol. IPT is a little bit more flexible, but there is some protocol as well. So these research methods are, I think, just easy to conduct, and therefore you can find evidence. But I would say, like, any form of therapy, just because it's hard to do research on pregnant women. So if you really enjoy somatic therapy, or if you really find that psychodynamic, psychoanalytic therapy is helpful for you, I would say any form of therapy is crucial.
I totally agree. And I think, there's lots of evidence that one of the most important predictors of positive response to therapy, positive change, is the relationship with the therapist. Not that that's all that matters, but more than the training or the modality or whatever. So if you are established with someone who you trust, or you've had therapy in the past with a certain person or through a certain modality, and it's been extremely beneficial to you, that's way more important than reinventing the wheel. If you're starting from scratch, sure, evidence base is evidence base. Go with good modalities, go with good referrals, but don't second guess it if you feel like you already have a good contact.
Mm-hmm. Yeah, there's been kind of a change in the therapy world in general, emphasizing the relational aspect, whereas before there was a lot more like analysis and the therapist is a blank slate but that's not so much the case now. So almost every therapist, if they are good at what they do, there's a pretty significant relational aspect to their work. So, moving on to the pharmacotherapy, that is something we as specialists manage. And the first line of medications for depression, whether during pregnancy or postpartum, are SSRIs. So, these are selective serotonin reuptake inhibitors. There have been over 1 million women studied with SSRIs, specifically more sertraline and escitalopram. But any of the SSRIs are actually recommended to be first line and safe during pregnancy and postpartum if you are nursing. And the SSRIs, we have a big variety. So there are several medications you can try. I will say that SNRIs are not within this recommendations, but sometimes when we try two SSRIs and it doesn't quite work, we might move on to SNRIs, which are serotonin norepinephrine reuptake inhibitors. These are medications like duloxetine or Cymbalta and Effexor or venlafaxine. And we are a little more hesitant with these because they have a little bit higher risk of high blood pressure during pregnancy, preeclampsia. So generally, we stay within the SSRI categories, but it doesn't mean that we do not prescribe SNRIs for depression and anxiety. And then just a word about antipsychotics. So, obviously for women with bipolar disorder, antipsychotics are very often utilized and generally safe and effective, especially the atypicals like olanzapine and risperidone. However, they do affect hormone levels, so you have to watch that. The typical antipsychotics like haloperidol, they tend to cause a little bit more movement issues, extrapyramidal side effects that can come up. So again, we're not saying it's off the table, but it is really looking at pros and cons. And there's a lot more research behind SSRIs than any of the other medication categories. Also, the few medications that we avoid are valproic acid or Depakote, carbamazepine, and lithium. But it is possible to be prescribed lithium during pregnancy and postpartum. Lithium is highly effective as a mood stabilizer, but it does carry some risks for the fetus and some risks for the mother as well. And the reason for that is because for pregnant women, their blood volume increases up to 50%, and it has to be cleared by the kidneys. Lithium is cleared mainly by the kidneys, so it's really hard to assess for therapeutic level during pregnancy with lithium. Also, it does present in breast milk. So if you're thinking of nursing, that's something to, again, talk with your psychiatrist and your OBGYN about. And then just going back to valproic acid and carbamazepine, the risk of that. So for medical students or residents out there, it's shown to cause neurotube defects. It's shown to cause autism, neurocognitive issues. And so we do tend to avoid those two medications.
Yeah, I think it's there are people who specialize in this and make their whole careers out of perinatal mental health, maternal mental health, and I've heard that it's a very individualized approach, right?
Mhm.
That going into mania with psychotic features can also be damaging to the mother and to the developing fetus. And so I've certainly heard of patients who, with careful observation, do stay on lithium if they've
Mhm.
been started on it and they're very stable and they're watched and observed.
Mhm.
So I don't think it's a contraindication. I don't think it means that you can't be on those medications. But I think the idea of, well, now that you're pregnant, you must compromise your own mental health stability to be sort of perfect in a way. I also think that can be a tough message.
Absolutely. I couldn't agree more. Yeah, there's no black and white answer with these. It's weighing the pros and cons. And like you said, manic break or psychotic break is detrimental. Infanticide is a real problem. Very rare, but it can happen. And so it's like, which risk are you taking? Are you taking the risk of exposure of depression and psychosis, or are you taking the risk of medications? So
Right.
it's a really hard conversation, but a conversation that needs to be had.
Mhm. There are new classes of medications, two neuroactive steroid medications that have been released and are approved specifically for the perinatal mental health field, which is kind of the first time in history. In our training, we've had
Mhm.
some exposure to some of these agents, but both of these classes of medications were released well after I completed my training. And so I am far from an expert in these. And so Xarelto is probably the more well-known just because it's been around a little bit longer.
I
Brexanolone.
don't know. Yeah. The
Um,
names.
the downside is it has to be given via IV. It's not something that people can take in the home, but the upside is that in trials, there's an efficacy of onset within 24 hours. SSRIs, we start a medication at a low dose and we say we'll see in about a month if there's an effect. And even then, it's probably going to be a mild effect and we're probably going to have to increase the dose. Somebody can feel better in a day, less than a day. So it can be, I would argue, life-saving in the right situations. There is now a pill neuroactive steroid called Zurzuvae.
Zurzuvae.
Sure.
Sure.
Zuranolone. It is once a day for about 14 days. It's also supposed to be very fast onset. It does have some side effects, but interestingly, it's for postpartum depression. It is not to be taken while someone is pregnant. I think that's really important. So these are included in the updated American College of Obstetrics and Gynecology guidelines for postpartum depression. So this is kind of a newer field that we're just starting to branch into. This is yet another reason that this is a whole field of mental health, and there are specialists in this. And so another option is to consult with an expert in perinatal mental health who is probably way more up on these types of novel agents.
Yeah. And I'm just looking it up actually now because I'm curious. There's really only a handful of perinatal psychiatry or reproductive psychiatry, is what they call it, fellowship offered throughout the country. This is a 1 year fellowship. So you spend an extra year in training just studying and learning about this. And there are not very many programs at all. So yeah, very much a highly specialized field, as it should be. But
Mm-hmm.
yeah, I think we're still learning about this every day. There's also interesting new approaches that are non-pharmacological that involve neuromodulation. So TMS has been popular and made a little more mainstream lately, I think, especially with the recent study out of Stanford that studied the effects of intense, repetitive TMS, like 10 times a day for a short period of time, rather than weekly sessions for a very extensive period of time. So RTMS, or repetitive transcranial magnetic stimulation, has no risk of drug exposure, which makes it especially attractive in pregnancy. And there have been small trials to show that it's effective. But again, you do have to find specialized centers. These are outpatient centers, but you do have to, most of the time, pay out of pocket. So that is the kind of barrier to getting these treatments. And then, of course, we do have ECT, but that is reserved for very severe treatment refractory cases with acute safety emergencies. So we're talking about severe psychosis or severe mania, severe melancholic depression. ECT can be very safe and effective, but requires extensive monitoring. Yes. So those are the big treatment approaches that we have right now. But I think it's important to kind of pause and look at the bigger picture. And so that's why we really do want to talk about paternal perinatal mental health, or I guess you could call it partner perinatal mental health as well. So yeah, expanding to the family as a unit and thinking about how the dynamics change and supporting everybody in that unit is really important. So specifically paternal mental health. So we're talking about the father right now. Nearly 1 in 10 new fathers experience depression, peaking around 3 to 6 months postpartum. And men experience up to a 68% increase in depressive symptoms in the first 5 years of fatherhood. So we're not talking about just the first year, the infant period. We're talking about toddlerhood and preschool age. It's a long time to be paying attention to. And up to half of men whose partners experience postpartum depression will experience postpartum depression themselves. That's a pretty heavy statistic, and it only makes sense, if the mother is experiencing a lot of depressive symptoms and the father is having to take on all of the household chores or all of the finances or all of the childcare, it can be really rough on that parent. So partner support is one of the strongest protective factors for maternal perinatal mental health. So even during pregnancy, if you're starting to experience that anxiety and you're thinking about how your life will change as a new father, it's really important to get into therapy, get that out of you and make it more concrete, more tangible, so that it's not swimming in the darkness of your mind and taking over you when you're least expecting it, like when your baby arrives.
Right. Yep. That is so important. I think it's so hard because everyone's trying to do their best and everyone's trying to be supportive. And the fact is that this is a new endeavor for both parties. And so figuring out how to support each other and how to take each other into consideration. And I do think a lot of the focus, not incorrectly, falls on the person who is bearing and carrying the physical developing infant. But even then, the people who support them can also benefit from mental health care too.
Yeah. And, in terms of risk factors to consider, if you are someone who has family history of depression or a history of depression or anxiety yourself, definitely this is something to watch out for. The lack of sleep is a big thing. There is a kind of a culture of like, I can survive with very little sleep, and that's a virtue or a sign of success. But when you are in the thick of it, you're having to juggle a million things and you're sleeping barely 3-4 hours a day, if that, it's going to take a toll on you.
Absolutely.
Yeah, it's going to start in your body, and then eventually you're going to feel that numbness that you're just going through the routine. And so sleep is so vital. and it should not be neglected.
Yep, sleep is an important part of life. It's when your body heals, restores, when you consolidate learning, consolidate memory. Lack of sleep can be a risk factor for dementia, for cognitive loss. I could go on for a long time about how important sleep is, so don't underestimate it.
Mm-hmm. Right. And then speaking more to fathers, there might be a way in which they process the depression differently. And so fathers are less likely to report sadness and more likely to report masked symptoms through throwing themselves into work or increasing their substance use, whether it's alcohol, marijuana, nicotine, things like that. And then the interesting thing about that too is most likely the father's not going to want to do those things in front of the baby, right? So then they are isolating themselves, they're leaving the home and finding ways to become more and more distant that way. And then there's shame and guilt associated with that. And so they might not be honest about what they're turning to cope. And so there's an emotional, psychological isolation as well. They may feel more anger or irritability. So, sadness is not so much acceptable, but anger and irritability is. And then there really isn't a screening tool for paternal mental health, depression, anxiety. There's one for women, the Edinburgh, that's been developed, and really this is not an area that's been studied. So just want to say to all the fathers out there that this is something we're still working on to develop more tools.
I think that's really true. And it's something that we run into a lot in various dyads, whether it's mother-child, mother-father, whatever it might be. But the idea of I can be the strong one and my partner's going through so much. I'm fine. Don't even worry about me. I'll take care of it. And then I'll just go off and punch the wall or drink or go to work. That's dealing with it, which is not dealing with it. And I think the message is taking care of yourself is taking care of your partner. That is how you show up, and that is how you are available and there to be that member of the family who can do that for the other person. So neglecting yourself is neglecting your partner, and taking care of yourself is taking care of your partner. So it's the lifeguard motto, like you have to be okay first. You got to put your own mask on first, and then you can be fully there for those other members of your family.
Yeah, and there is a sense of once you take care of yourself, you're feeling ready to help, but you're not sure what to do, what to help with. It could be overwhelming. So they might turn to things like taking care of the house or finances, things outside the home that doesn't necessarily have to do with the baby, but then you're building that attachment with the baby. And so there's kind of this sense of helplessness. You want to be the one who provides, or you want to be the one who's on top of things and knowing everything that's about to happen. And it just doesn't come as naturally for the fathers because the biological changes are not happening to them. So there's not as much of an intuitive sense, and that can make them feel really bad about themselves.
Yeah, and I think everyone learns how to play those roles through whatever societal influences they have, whether that's their own family, whether that's, I don't know, TV, movies, books. And I think there's no right way. So, the old traditional nuclear family model of the father's the provider, the mother stays at home with the kids. That's not necessarily correct, but some people might go back to that and just throw themselves into work, not because they're depressed, but because they think that's their role. I need to make as much money as possible to fund the college fund and to do whatever. Or other people might take off from work and stay home just eagerly waiting for something to do, to be available and around. And the other partner is sitting there like, don't you have somewhere to be? Shouldn't you go, get away, do something. So sort of figuring that out as a couple and negotiating that. And it's all about communication and being able to talk about that. And sometimes there is couples therapy, which can be really beneficial at any point in life, especially when there's a big change. And once again, I can't imagine a bigger change than having a child.
Yeah. If I could recommend couples therapy to everybody, right? Or just therapy to everybody, but
I know.
Yeah. So important. So we did want to give space for that, to think of the family as a unit and really also pay attention to the partner, the father, and what they're going through. We do also want to touch on special populations as well. And this, again, we're touching the tip of the iceberg here, but pregnancy loss and infertility is so devastating. Not only the physical toll it takes, the hormonal changes, the bodily changes, but of course, the psychological toll of guilt, fear, and uncertainty, unpredictability, all of these things. Nowadays, we have a lot of methods to counter this. So, infertility treatments like IVF, egg freezing, hormonal treatments, these are great options, but it comes down to access issues. It comes down to politics, which is such a headache right now. And also comes down to stigma, cultural values, all of these things. And we just want to recognize that.
Yeah, I can't say it better. It's an incredibly complicated, very difficult time, and not to add more sort of stress or pressure or anxiety to it, but unfortunately, people have trouble conceiving. There are lost pregnancies, there are stillbirths, there are tragedies that happen every day. And I think being able to recognize that for what it is and to seek help and not just turn inwards and sort of collapse, and you don't have to go through it alone. There are other people who are struggling with this. It's not shameful. It's not embarrassing. It can feel like it. It's not any sort of a comment on the mother or the father as people. It's just really hard and unfortunate.
Yeah. Yeah, and if therapy is not possible, like because of access, because of stigma, because of whatever, then I do find that nowadays these online communities can be very helpful. So, I don't like social media, I don't encourage it, but there are certain groups that are more meticulous about what content they put out there. There is a supportive and collaborative energy about them that people find very, very helpful. Also, if you need to know whether something is appropriate or inappropriate, yes, we do recommend talking to a professional, a doctor. Googling is really not the best thing, but in the moment, it could be helpful if you could just settle your mind just for that moment and see that there are this many possible answers. And so this is one of those niche areas where online resources can be incredibly helpful.
Mm-hmm.
And then the other special populations that we like to touch on are the babies that unfortunately have to go through NICU stays. So the baby is viable at 24 weeks, which is so crazy to think about. They're so tiny. They're barely a pound. And so anything can happen at, 24 weeks or on. If the baby is born very much early like that, then you do have the risk for the mom, the dad, everybody involved to have higher rates of PTSD, anxiety, depression. The NICU experience is inherently traumatic. There's so much attachment disruption, medical complexity, your cortisol skyrockets. Having said that, a lot of NICU babies do very well. They grow very strong and they're happy, very active children, but it is just an extremely traumatic experience for the parents and the families.
And I'm glad there's more of a recognition of that. I think the models of the NICU are changing, whereas traditionally they were very focused on the life of the infant. ICU's in the title. You take care of the identified patient, but now it's so much more family centered and taking care of the parents, which does take care of the patient in a way. There's still the idea of that maternal touch and paternal touch that is important, and there's bonding time, and there are other things that are incorporated into modern NICUs that I think do recognize this. But even with that, acknowledging the amount of stress through that experience and paying specific attention to that.
Yeah, and I don't actually know the details of how often you can see your baby in the NICU. Certainly, you can visit them daily, but how many hours? When can you visit? It's so dependent on the hospital, the policies. And as far as I know, there are no maternal infant pair psychiatric units that exist. It's it just doesn't exist. It would be such a dream. But of course, just the logistics of that is so much to consider. You have to have NICU nurses, you have to have specialized pediatricians, specialized psychiatrists, and staff that's trained in a very niche field. We don't have resources like that, unfortunately. So it's something that people are kind of winging as they go when their baby is in the NICU a month early, 2 months early. You're just making it work. You're in survival mode. And so, again, just to kind of pause and pay attention to what's your body feeling, where's the tension, where are you feeling dissociated or numb. These are really important clues to where you are in your own mental health so you can show up and be the best parent you can be. So that concludes what we wanted to bring up today. We do have a lot of resources we can share with you. I find it so interesting, but perinatal psychiatry is like the intersection between very concrete answers that we need right away and more abstract, big picture, conceptual things that need to be an undercurrent within the treatment, because taking care of a baby, a newborn, an infant, a lot of things have to be fairly immediate. You have to have answers, at least some sort of guidance. So the MGH Center for Women's Mental Health, it's womensmentalhealth.org, is the premier academic resource. They have great databases for medication safety guidelines, clinical guidelines, patient education guidelines. So that's a great one. Postpartum.net is another good one. They also have a helpline that you can call and provider directory if you're looking for someone specific. LactMed through the NIH is also a great resource to look up drug safety for breastfeeding. You can search by medication. And then just a couple of more. Mother2baby.org also talks about drug safety in pregnancy. They have facts sheets and consultation services. And then the PSI provider training of Postpartum Support International, you can actually get certified in perinatal mental health. So if you are a provider out there and you want to learn more about this, there's also resources for that too.
Yep. And there are fellowships. I don't believe this is an accredited specialty through ACGME, but UCLA has one, Hopkins has one, MGH obviously has one. So if you are a mental health provider, psychiatrist who's interested in really diving into this field, it is a very exciting, very emerging field. Right. And it's funny, you talked about LactMed. We haven't even talked about lactation consulting and everything that goes along with that. There's a whole world of perinatal mental health that I'm glad is increasingly recognized as an important specialty.
Mm-hmm. Yeah, you're right. That was a whole, yeah, we glazed over that, but that is a whole thing of the pressure to provide in that very concrete way can be so much for the mom. So, yeah. Okay, last thoughts for this.
In a way, I think it's similar to a lot of what we say, that people have been having babies since literally the first humans were around. And because of that, because it's such a part of life, I think there's an expectation that you just do it and you just sort of get on with it. But really, even if something is constant and inevitable. I mean, think about it. Death is inevitable, but we have lots of grief counselors. We have lots of mental health around that. It seems so obvious in retrospect that because this is such an important part of life, we should be paying attention to it. And we should be diving into mental health and mental wellness and how it wraps around this field. And it's not just expected that, oh, if you're feeling a certain type of way, everybody does. You're fine. Just go through it. And it's shameful and embarrassing. And just because your experience was different means that there's something wrong with you. I mean, there's so much shame and guilt and secrecy, and yet false normalcy around this really incredibly dynamic, important, unique experience that people go through.
Yeah. And I was thinking about how when something is very difficult, you start with focusing on that thing. So, for example, we can all imagine childbirth is just absolutely horrific, right? The amount of pain, the mess, the unpredictability, all of it that goes into it. So I think for a long time, we really focused on that moment, providing as much preventative and safety measures as possible surrounding childbirth. And then you kind of say, okay, the baby's here, everything's good, let's just go back to normal life. It does not work that way. And the 9 months leading up to it, it's not that way. The years after it, it's not the same. And so, yeah, I love that we're actually really zooming out and taking a look at the whole picture, paying attention to different phases. It's like a developmental phase of this whole experience. And so, yeah, reach out, ask for help, and always remember that you are not alone in this journey.